Bismillahirrahmanirrahim. Assalamu alaikum. Today we will start a series of sessions regarding a very important topic that is related with the carcinoma of the larynx. So let's start today's discussion. It is also abbreviated as CA larynx. You are requested to subscribe the channel so you are not going to miss any succeeding video. It is the most common carcinoma of the upper aerodigestive tract. It is called as laryngeal cancer or cancer of the larynx in layman terms. Technically, we call it as the laryngeal carcinoma, and usually it is more than 90% of the cases squamous cell carcinoma, reflecting its origin from the lining of the larynx. It can develop in any part of the larynx, and cure rate definitely will be affected by its location and stage of the tumor at the time of presentation. We know that larynx anatomically is divided into three subdivisions, that is supraglottis, glottis, and subglottis. And here you can see it is in the order of occurrence of malignancy. The most common site which is being affected by the carcinoma of the larynx is glottis, followed by supraglottis, and then is the subglottic region. It is the sixth commonest malignancy worldwide. 10,000 new cases every year are being reported in USA. Its incidence is 1% of all malignancies in UK. Males are affected more, 4 to 5 times more, usually in the age of 55 plus, and laryngeal carcinoma is approximately 4 per 100,000. But incidence in females is increasing in the Western world during past few years. 4,000 persons with carcinoma of the larynx will die every year, and 90% of the untreated patients they will die within 3 years. But it is a potentially curable if diagnosed and treated early. Its risk factors are predisposing factors, just like any other head and neck cancer. At the top are the tobacco, smoking, and then is the alcohol, and a combo of these two is even more lethal. Individually you can see very well that the alcohol, this smoking alone, it is 2 to 25 times, while alcohol it is 2 to 6 times. But a combo effect of these, if someone is smoker and at the same time he is alcoholic also, 40 to 100 1000 times are the more chances of getting these types of carcinomas. Even passive smoker is also more prone to. Then some occupational hazards, if someone is exposed to asbestos or paint fumes or working in cement factories and chemicals, tar products, leather and metals. So all those can be predisposing factors. So one should try to quit smoking. It doesn't lead to anywhere. Then certain other factors, like if there is continuous straining of the voice, especially in cases of chronic laryngitis, then nutritional deficiencies, immune system if it is weakened due to some other disease like organ transplant or AIDS, genetic factors, and if neck has been irradiated for some other reason previously. So all those can be predisposing factors. So age is a major risk factor, 50 plus. Then males are more prone to get this, 4 times more as compared to females. And African Americans, they are more likely to get as compared to whites. Now, in 1950s, the ratio was 15 to 1 between males and females. Males were 15 times more prone to, which has been changed to 5 to 1 in 2000. It means that the incidence of cancer or carcinoma of the larynx has increased in females. This may be due to shifts in smoking patterns in females in these decades. Almost 1 in 4 patients, that means 25% of the patients who are having a head and neck tumor, they will be having another secondary primary head and neck tumor. So detailed head and neck examination is mandatory in any case of head and neck tumor. Occupational hazards, I just mentioned, if the patients are exposed to sulfuric acid mist or nickel or asbestos, they are more prone to get such kind of malignancies. Majority of the larynx carcinoma, it is squamous cell carcinoma in more than 90 to 95% of the cases, and there may be some variants of squamous cell carcinoma also, like verrucous carcinoma. And to complete the list, we can add that there can be chances of spindle cell carcinoma, malignant salivary gland tumors, sarcomas, fibrosarcomas, chondrosarcoma, and adenosarcomas, etc. But still, in more than 95% of the cases, either it is squamous cell carcinoma or it is a variant of squamous cell carcinoma in the form of verrucous carcinoma. Anatomically, as we just mentioned, we divide it into 3 parts: supraglottis, glottis, and subglottis. Supraglottis, it includes the epiglottis, then it includes the ariepiglottic folds, arytenoids, and then false vocal cords, which are also known as vestibular folds or ventricular folds, and of course the ventricles. While the glottic region, it includes true vocal cords or true vocal folds with anterior and posterior commissures. Subglottic has got no subsite, but it is the area which is there from the vocal cords above up to the trachea below. So this area, it is called as subglottic area. Pre-epiglottic fat space is very important because carcinomas can spread and can involve that space. This is just in front of the epiglottis, as the name indicates, pre-epiglottic, and it has got a fat, and it can be invaded by advanced carcinomas of the larynx. Then lymphatic spread for any malignancy, it is very important, and it is very important in staging of any tumor also. So we must have an idea of. So first echelon lymphatics for the supraglottic larynx, they are the subdigastric nodes and the middle anterior cervical nodes, and the second echelon lymphatics are the lower anterior cervical nodes. As far as the subglottic region is concerned, Delphian node, the lower anterior cervical and paratracheal nodes and supraclavicular nodes are the first echelon, and the second echelon lymphatics are the mediastinal lymph nodes. Glottic region, we know it is a watershed. It has not got any lymphatic supply. So from glottic carcinoma, the lymph node involvement will only be when the disease is at advanced stage, and from glottic region it has spread to involve either the supraglottis or the subglottic region, or all the 3 regions are involved, in which case we call it as a transglottic carcinoma. Then will be the lymphatic spread in case of glottic carcinoma. And glottic and subglottic tumors, they metastasize to ipsilateral lymph nodes, but supraglottic tumors, they often spread to the nodes on both sides of the neck. And this is a very important practical point. So as you can see in this picture that 65% of the cases, they will be having glottic carcinoma. So the glottis is the region which is most commonly involved, followed by supraglottic, which is involved in 35% of the cases, and only 1% of the cases they will be having subglottic carcinoma in isolation, because most subglottic masses, actually they are the extension from the glottic carcinoma, so that in isolation separately the subglottic region is involved only in 1%. Rest of this glottic carcinoma can invade the subglottic region as well. So this is a picture showing us the exophytic lesion over the vocal cords. You can see another picture, endoscopic picture showing us a huge mass involving the anterior commissure and the vocal cords. In supraglottic region, as we know that there are so many structures are involved. So in the supraglottic region, the epiglottis is most frequently involved in case of carcinoma of the larynx. And these lesions, they are usually exophytic and circumferential lesions, while the tumors of the aryepiglottic folds, which is also a subsite of supraglottis, you can say, these are also typically exophytic lesions when detected early, and they are confined laterally along the aryepiglottic folds. Advanced lesions from the aryepiglottic folds, they may extend laterally to involve the adjacent wall of the pyriform fossa or medially to invade the epiglottis. As far as the squamous cell carcinomas of the false vocal cords or the laryngeal ventricles are concerned, they tend to be ulcerative and infiltrative with a limited exophytic component. Deep invasion by such tumors, they result in their access to the paraglottic space, and this may lead to fixation of the supraglottic larynx. Because of their close proximity, these tumors may extend inferiorly to involve the true vocal cords. In glottic carcinoma, the true vocal cords, most common site of the CA larynx, as we saw that 65% of the carcinomas they occur in the glottic region, and true vocal cords are involved. And the ratio of carcinoma, glottic carcinoma versus supraglottic carcinoma is 3 to 1. So glottic carcinoma is 3 times more common as compared to supraglottic carcinoma. And out of this glottic region, the anterior portion of the true vocal cords is more prone to be affected, and the most lesions they occur along the free margin of the vocal cords. Then this tumor anteriorly, it may extend to anterior commissure, where it may involve the contralateral true vocal cord. So it will be a direct extension. Then likelihood of the nodal involvement, I just mentioned because it is a watershed, it does not have a lymphatic supply, the glottic region. So glottic nodal involvement will depend upon the stage of the tumor. So in T1 lesions, only 2% are the chances, while this will increase as the stage will be advanced to T3 and T4, in which case it may be up to 20% lymph node involvement because of the involvement of the supraglottic or subglottic region, because at that time the tumor has extended to involve these anatomical areas. As far as subglottic carcinoma is concerned, in the percentage we saw only 1%, so it is very rare, and overall it may account for 5% of all the laryngeal carcinomas. Mostly these tumors in the subglottic region, they are the extension of the glottic tumors. When present, these lesions are characteristically circumferential, and they often extend to involve the undersurface of the true vocal cords. And they have a tendency for early invasion for the cricoid cartilage and extension through it through the cricothyroid membrane. So if you think that this is beneficial for you, share it with your friends and subscribe the channel, because we will continue with the route of spread for these tumors, and then their clinical features, investigation, and of course management. So till then, Allah Hafiz.